Hello, my name is Edward Felix. I am the medical director at the Clovis Bariatric Weight Loss Center. Uh, I'm going to talk to you today about options for weight loss, mainly bariatric surgery. The Clovis Bariatric Center has been accredited as an American College of Surgeons Bariatric Center of Excellence. In addition, it is one of the few Blue Cross and Blue Shield Centers of Excellence in the state of California. We have been a center of excellence since the designation began and are now ranked as one of the top bariatric centers in the state of California as well as nationally. What we're going to talk about today is what is obesity, why is this a problem, how can it be treated, medical management, and surgical treatment. First of all, what is obesity? We gauge obesity now by what is called BMI, Body Mass Index. That's your weight versus your height. That is the most accurate way that we have today to tell that if you are in the normal or abnormal range. Normal is 19 to 25. Overweight is considered 25 to 30, and obese is 30 to 35. In general, we don't start thinking about doing surgical treatment until you've either reached 35 to 40 with medical problems or above 40 BMI. More recently, this has been revised, and we'll talk about that later. Unfortunately now, most adults in the United States are overweight. 67% of adults and as many as 33% of children are now overweight. And this keeps going up year by year. 30% of our population in the United States are in fact obese. And as many as 15 million people have become morbidly obese. In other words, their BMI is greater than 40. Why not just manage obesity or morbid obesity medically? The reason is, unfortunately, when patients or people become morbidly obese, when their BMI is 35 or above, it is almost impossible for them to lose enough weight to influence their medical problems. There are medications, appetite suppressants, and even fat blockers to help, but it has been well shown that 95% of people at 1 year will fail medical management of morbid obesity. Exercise is important and behavioral change is important, but both of these will not add enough to make weight loss successful when the BMI becomes 35 or greater. Who is a candidate, therefore, for surgery? In the United States, we're very strict. If your BMI is 35 to 40 with medical problems or greater than 40 BMI, you are definitely a candidate. And now the FDA has said that if your BMI is 30 to 35 with medical problems or 35 to 40 without medical problems, you may be a candidate for the lap band. What I'd like to do now is present the different options we have for surgical treatment. What we do at the Clovis Hospital are what are called restrictive procedures. To understand that, you must understand what happens when you eat. Obviously, when you eat food, it goes in your mouth, down your esophagus, it then goes to the stomach, which acts as a holding chamber. The stomach then slowly releases the food into your intestine, where it mixes with juice from your liver to digest fat and juice from your pancreas to digest protein. It then has to mix over 10 or 15 feet for you to absorb those nutrients to spread them through your body, through your blood system. If it doesn't get absorbed or the intestine is short-circuited, you don't get enough nutrients. Therefore, there are two ways we can influence your calorie intake and make you lose weight. If we bypass most of your intestine, those are called malabsorptive procedures. We do not perform those at the Clovis Hospital. We don't because in general the weight loss is too great and long-term complications can be severe. What we do at the Clovis Bariatric Center are what are called restrictive procedures. There are three main procedures we perform, and we'll talk about each of those individually. The first is the Roux-en-Y gastric bypass. The next is the adjustable gastric band. And finally, the newest, the sleeve gastrectomy. We will talk about the gastric bypass first because it's been around the longest, has the longest history, has the most successful weight loss and track record, and therefore we consider it the gold standard for other procedures. Before we do that, however, let's talk about how we do surgery. When we do surgery, there's two ways to do it. One is the old-fashioned way, the one that's been around for hundreds of years, and that is to make a long incision, open you up or open the patient up, operate and do the procedure through an open conventional technique. As stated, this has been around for years. Over the last 10 to 15 years, however, we've made great progress. We are now doing things mostly laparoscopically. What does that mean? What that means is we make a series of small little incisions, and using a camera and a telescope, we're able to do this just as if we were doing open surgery. However, we avoid the great big incision. We do it as laparoscopic surgery for several reasons. One, it's better for you in the long run. There are less chances of complications. Two, there's a lot less pain postoperatively. And three, the recovery is rather rapid. You're able to go home in just a day or two after a bypass or a sleeve gastrectomy, and even go home the same day if you have a lap band. And finally, it's much more cosmetic. The little scars can barely be seen in most patients once they heal. We perform most of our surgery, over 95% of it, laparoscopically at the Clovis Medical Weight Loss Center. There are a few patients, however, which will require open surgery, and we will discuss that at a later time. Let's go on to the gastric bypass, or as it's known, Roux-en-Y gastric bypass. As stated, we consider that the gold standard because it has the best and most consistent results. More than 95% of patients will lose at least half or 50% of their excess weight. Why is this important? And why do we consider that a success? We do because if you lose at least half of your excess weight, you have a high likelihood of either preventing or eliminating your medical problems. In fact, the average is about 75% loss of excess weight in most patients. And some patients lose as much as 90 to 100% of their excess. How does the gastric bypass work? It works by making a small pouch out of the top of your stomach and then hooking it up to the intestine as seen in the picture, and then reconnecting the intestine farther down so that the juice from the old stomach, the pancreas, and the liver meet up with the food you've eaten and you digest food normally. This is not a malabsorptive operation, but rather a restrictive one. It restricts the amount of calories you take in. And we know that 3,500 calories equals a pound. If you take in 3,500 calories more than you work off, you will gain a pound. And if you burn 3,500 calories more than you take in, you lose a pound. And so this operation works by restricting the number of calories you take in, and gradually, over time, you lose weight. At about 6 months to a year, you're able to eat fairly normally, take in a normal diet, and your weight loss plateaus at the 50 to 90% excess weight loss. Every operation we do, however, has risks. The main risks of a bypass are bleeding, or obstruction, or even leak. The one we worry about the most is the leak, and in our hands, fortunately, that does not occur very often. Long-term risks of the operation are things like obstruction and ulcer. As stated, 95% of patients will lose at least a half of their excess weight by the first year. Some of our bigger patients, who may be 400, 500, 600 pounds, will take longer. The most we've ever seen anyone lose in a year is about 250 pounds. The usual is about 100. To reach the 75 or above excess weight loss, however, takes a lot of work on the part of the patient. The unfortunate thing about all surgery is there is a possibility for weight regain, and about 20% of patients will regain some to even a majority of their weight. This is unusual, however, if patients continue to follow up as they are told on a yearly basis. The outcome is determined by you. You must take in a high-protein diet because you require so much protein a day. You must exercise, and you must follow up with certain vitamins, calcium, and other nutrients to maintain your healthy weight loss. What happens to your medical problems? Diabetes is totally resolved in as many as 80% of patients and improved in the other 20% who are usually patients who had long-term adult onset diabetes. The best operation for diabetes is the gastric bypass, because we now know that if the first loop of intestine is bypassed, that the diabetes will almost instantly go away before you've even lost a pound. Cholesterol, high blood pressure, heart disease, all of those are improved by weight loss, and even sleep apnea is improved in 75% of patients. Reflux is improved in 80% of patients. And even depression in most patients is improved. There are general problems with surgery, and we watch for those carefully. Things like pneumonia, wound infections, blood clots are uncommon, but they're things that we must watch for, and it's why we ambulate or get our patients up and about so quickly. We've already talked about leaks and other problems. Death can occur with any surgery, but it is highly unlikely. Clovis Community Hospital has an amazing track record with a less than 0.1% mortality rate over the last 10 years. Let's talk about lap band. Lap band's a little bit newer operation. It's been around for approximately 8 to 10 years now, and it was begun for those patients who were just hesitant or resistant to have bypass or other surgery. It works by restricting how much food and fluid can reach the stomach. It does cause some satiety or decrease in appetite, but mainly it's a restrictive operation. It restricts how much and how fast you can eat. The weight loss is much slower than bypass. It takes anywhere from 1 to 3 years, and the average weight loss, instead of being 75%, is about 50% of the excess. There are those patients, however, who reach as much as 75 to 90%, who are very active and very cooperative with the program. The band takes a tremendous amount of discipline. It is not a forced plan as is the bypass, but it does work. The unfortunate thing about the band is many as 30 to 35% of patients will fail because of their lack of cooperation, their inability to come in for appointments and band adjustments, and because some problems of their compatibility with the band. The band requires adjustments. It requires the patient to come in for what we call band fills every 6 to 8 weeks, and this is essential. One of the main reasons people fail their band surgery is that they don't appear or come in for their adjustments. It is very important that the patients come in for their adjustments. Most band failures occur because of their lack of attention to this detail. Let's talk about the last option. About 5 years ago, a surgeon came up with the idea that he would do what was called a two-stage bypass. And he did an operation where he created a long tube, which you see in this picture, out of the stomach. This long tube was called a sleeve. He was then to come back 6 months or a year later and do a bypass. And what was discovered was that if you just make a long tube out of the stomach, 75% of patients never need to come back for the second part of the operation and have a very successful weight loss. So what was begun about 5 years ago was a study to see if sleeve gastrectomy could be used as a primary operation for weight loss. And what we found was, in fact, that sleeve gastrectomy lays somewhere between bypass and bands. It's not quite as good an operation as a bypass, but it's much better operation than a band. The average weight loss is about 60 to 75%, and the success rate is about 75% at 1 year. So now sleeve gastrectomy is being offered by our center and is now being covered by most insurance companies as an alternative to bypass or band. It works by purely restricting the amount you can eat and by reducing a hormone that normally occurs in the stomach. This hormone is called ghrelin. Ghrelin is the hormone that makes you want to eat. And when you do a bypass, you bypass that ghrelin, and when you do a sleeve and throw out the portion of the stomach, as you see in the picture called the resected stomach, that ghrelin goes down. So it not only decreases your appetite, but improves your diabetes if you have a adult onset diabetic condition. So sleeve is now a new alternative. It is now being reimbursed by insurance companies, and it is one being offered by our hospital. The advantages of the sleeve are that the long-term risks and complication rate are exceedingly small. There are problems with bypass and bands, which are totally eliminated by the sleeve, and it is now probably the fastest growing operation worldwide. It is important to understand that no matter what operation you choose, whether it's a sleeve, whether it's a band, or it's a bypass, you must change your eating habits. You must learn to eat 3 meals a day and not graze. You must learn to eat slowly and stop when you're full. For most of the surgeries, you need to separate liquids and solids and not drink with your meal so that you wash the food out of the stomach, so you liquefy the meal and are allowed to eat more. And you must learn to avoid high-calorie liquids because that is one of the major causes of defeat for any of the operations. When you have surgery, I know everybody's worrying obviously about complications and chances of dying from their surgery, and that's what has kept many patients away from the operative table. We used to say that the chance of dying from surgery was about 2%. Now we know that in centers of excellence like ours, it's less than 1%, and in centers of excellence, it's less than 0.2 to 0.3%, and in our center, in fact, it's less than 0.1%. To put that in perspective, if someone has a routine gallbladder removal in the United States, the chances of dying from that surgery are 0.4%. So in fact, the gastric bypass at most centers of excellence, including ours in the United States, the chances of dying are less from a bypass than a routine gallbladder surgery. But it is big-time surgery, where you have risks of blood clots, anesthesia problems, leaks, and even cardiovascular problems. But this is why it's so important in the United States now to have your surgery done at a center of excellence where the risks are markedly decreased by the professional team that center has. When we decide to do surgery, we always weigh the risks of dying from your obesity versus the surgery. And we now know that in the United States, the chances of dying from morbid obesity reaches 20 to 25% over not being morbidly obese. And that's why we recommend surgery for those who are in the morbid obesity category, 35 or above with medical problems, or 40 or above without medical problems. Patients change dramatically. These are just examples of some of our patients. Others you will see when you come to our center. But patients change dramatically, not only in their appearance, but their outlook on life and what they're able to do and perform. Their family lives change. Everything is usually changed for the better. Some patients change in ways that you can't even recognize. This young man says his horse appreciates his weight loss as much as he does. There are a lot of questions that are frequently asked by our patients. Can I get pregnant? The answer is yes, but we'd like you to wait at least till a year after your bypass surgery or until you've plateaued after your band surgery. What happens if you get pregnant during that time? Nothing really terribly bad, but we have to watch you carefully. Can I drink? The answer is first, alcohol is a liquid calorie, so we try to get you to avoid it. And secondly, alcohol has to be avoided after bypass surgery in the first year because it's absorbed so rapidly. Can I travel after bypass or band surgery? The answer is again yes, but we'd like you to wait at least a month to do any serious traveling because of the risk of blood clots. Will I regain my weight? The answer is probably not, but the chances are you can gain some back. And if you're not attentive to your habits, if you don't change your habits and you don't come in for your visits, yes, you can gain a lot of your weight back. And that's why we feel it's so important that you return yearly, and we are there for you for the rest of your life. Will I need plastic surgery? And if so, when? The answer is you may. It's more common in women because their fat is distributed outside the abdomen, mostly underneath the skin. But not everybody needs plastic surgery. One should worry more about that medical problems that are caused by your obesity and not whether you're going to need some surgery to tuck up some of that extra skin. My feeling is that if you lose that weight, you deserve the plastic surgery if you want it, but not everybody needs it. So your next step is to decide whether bariatric surgery is for you, to come to one of our formal seminars to hear more about bypass, bands, and sleeve gastrectomy, and then decide what you want to do. After you've decided bypass, band, or sleeve surgery is for you, we will help guide you through the process. But one must remember that bariatric surgery is only the beginning. It is the start. You must learn to change your eating habits, your activities, if you want to maintain what you will start with your bariatric surgery. The next steps are to give us a call, make an appointment, and come to see us. Thank you very much. I look forward to meeting you and helping you in the future.